Welcome back to the ProPA podcast, where we simplify medicine one high-yield topic at a time. I'm your host, Prof. G, and today's MSK101 Clinical Medicine Brief is all about calcium pyrophosphate deposition disease, better known as pseudogout. In this episode, we'll cover high-yield facts about the disease to help you ace your PANCE or PANRE exam. We'll go over simple pathophys, key clinical clues, diagnosis, treatment pearls, and wrap up with a couple of board-style review questions. Let's dive in. Did you know pseudogout isn't just a fake version of gout? While the two are often confused, they involve completely different crystals, and pseudogout is actually the most common form of a crystal arthropathy after gout in elderly patients. So let's look at the kinder patho. What is pseudogout? Let's keep it simple. In pseudogout, you get deposition of calcium pyrophosphate dihydrate crystals. That's a mouthful. We call it CPPD for short, and this is within the joint space. These crystals trigger inflammation just like in gout, but they're rhomboid shaped and positively birefringent under polarized light. It's more common in older adults, especially those with underlying metabolic conditions like hyperparathyroidism, hemochromatosis, and hypomagnesemia. So, how do these patients present typically? Well, pseudogout often presents as an acute monoarticular arthritis, typically involving the knee, which is the most common joint, although it can also affect the wrist or the shoulder. Look for sudden onset of joint pain and swelling, warmth and erythema of the joint, and limited range of motion of the joint. Also, it's very common in elderly hospitalized patients. And unlike gout, pseudogout is more frequently affecting the larger joints and occurs in older adults. So, how do we make the diagnosis? Well, arthrocentesis is the gold standard. We're going to look for rhomboid shaped crystals that are positively birefringent under polarized light. You may also see some chondrocalcinosis or cartilage calcification on x ray. Another finding may be elevated white blood cells in synovial fluid, but no bacterial growth. Okay, so how do we treat pseudogout? Well, the first line, just like in gout, is going to be NSAIDs. Some alternative options will be the same colchicine, especially for prophylaxis or mild flares. We can also consider doing intra-articular corticosteroids, which is great for single joint involvement. Prophylactic therapy like low-dose colchicine may be used for recurrent attacks. But don't confuse it with gout, okay? The treatments are similar, but the crystal type and patient population tend to differ. So now let's look at some pearls and buzzwords, okay? So gout. Gout equals needle-shaped negatively birefringent crystals, whereas pseudogout is rhomboid-shaped positively birefringent. I know we've said this a bunch, y'all, but that's because this is so important in distinguishing the two. Also, think chondrocalcinosis on imaging. That is a classic finding of CPPD. Also, elderly, acutely swollen knee. Think pseudogout until proven otherwise. All right, now let's look at some PANCE style questions. Question 1. A 75-year-old woman presents with acute onset of right knee pain, swelling, and limited range of motion. She is afebrile. An arthrocentesis reveals rhomboid-shaped, positively birefringent crystals. What is the most likely diagnosis? Is it A, septic arthritis, B, gout, C, rheumatoid arthritis, or D, pseudogout? I'll give you a few seconds. Well, this one wasn't too difficult. We know the answer is D, pseudogout, and that is due to the findings on arthrocentesis as well as the presentation. Question 2. Which of the following is a radiographic finding commonly associated with CPPD or pseudogout? Is it A, rat bite erosions, B, chondrocalcinosis, D, joint space narrowing with osteophytes, or D, periarticular osteopenia? I'll give you a few seconds. If you said B, chondrocalcinosis, you are correct. Remember, rat bite erosions are more common in gout, whereas chondrocalcinosis more common in pseudogout. All right, and that's a wrap on CPPD or pseudogout. your second MSK101 Clinical Medicine Brief. Make sure you're subscribed to the Pro PA podcast so you never miss an episode. And if you're cramming for the PANCE, come back for these quick hits as often as you can. Until next time, this is the Pro PA podcast, where future pros in medicine are made. I'll catch you in the next episode.